don't worry. You can see the screen, is it? My
Yeah, I
screen
can
where
see the
you,
screen, but
yeah,
not much. Yeah.
now you can see the case.
Yes, now I can.
Don't worry, I will not open the timer yet. Okay, so just to let you know, there is some bit down. Okay, a little bit down.
Mm-hmm.
Okay, so when you read maybe until half or something, you tell me scroll down. Okay, I will open the three. Do you want to be after the 3 minutes timer to try to discuss the given data and then go through the case like
Okay,
we
yes.
did the next time,
Yeah,
like we did
yeah,
the
I
last
think.
time? Yeah, so you
Yeah, I think
will
that
be
that
able how
would
to
be.
think. Yeah, sure, sure, no problem.
Okay, can we scroll down? Can we scroll down, doctor?
Yeah, sure.
Can you scroll down?
Yeah, I think this is the last. Yeah,
The
this is
last one. Okay.
the next is the ECG.
Okay.
Okay, so let's bring it from the start. Let me just double check the recording working sometimes. The recording. Yeah, it's recording. So what do you think initially when you read the data, the data and the information that we have here?
I'm not sure because the main complaint says headache and dizziness, but I'm not sure what the patient has to say now. But it seems like patient has multiple problems like diabetes, hypertension, erectile dysfunction, and depression. And erectile dysfunction might be due to his diabetes, it could be due to his cholesterol, so it can be due to an organic cause as well. So we have to
Mhm.
keep that in mind. And then it seems that he's also started on the metazapine, which is an SNRI, which can also cause erectile dysfunction problem. So I'm not sure if the case will revolve around erectile dysfunction or whether it's more about headache and dizziness, because that information where it says 1 year ago, it didn't appear very clear to me that wanted to discuss with partner, but about an operation, but there's nothing written about an operation, so I didn't quite understand that bit.
So,
But how it
yeah.
can be related.
Yeah, yeah, but that's that. Yeah, so we had an approval that any information given is related. Okay,
Oh, okay.
this you need to put that concept in your mind,
Hmm.
please. Okay, any
Hmm.
data the examiner giving it to you, he need you
Hmm.
to use it. Okay, he's not giving it to you to lose your time. Okay,
Hmm.
he give it to you because he wants you to use it in the management plan. And
Hmm.
reflection to what you said, then you need them to know what happened from 1 year
Hmm.
ago and what is the problem and that happened to the partner and making him feel guilty. Who's the
Hmm.
partner? Okay, and what
Feeling
type of
guilty
the
for his
partner?
partner condition. Partner does
Yes,
not share this field with him.
yeah. So you need to ask, okay, who's the partner?
Okay.
Okay, what type is the partner is male,
Hmm.
female? That's important, okay, to
Hmm.
ask. So don't presume it's female. Okay, that's important to ask. This is one.
Hmm.
The other thing, because it's a trick that
Hmm.
he is on sildenafil. In
Hmm.
this case, it's yes, it's for erectile dysfunction. But if you see the sildenafil, it's not always for erectile dysfunction, and that's important to know. Okay, either in real life, either maybe they will bring some complicated cases in the future like that, because we are using sildenafil in pulmonary hypertension. So
Hmm.
sildenafil is used in primary or secondary pulmonary hypertension, or using sildenafil on. So on the maximum dose is 50 milligram, and usually it will not be so 50 milligram TDS. Okay, it will not be once daily. Okay, or once. Here you can see there is no specification of the frequency because it's when needed. Okay, before sex.
Hmm.
But if you find it in the exam or even in the patient's notes in real life, you find sildenafil 25, usually above 65, we're starting 25 TDS or 50 TDS. This is usually for pulmonary hypertension, either primary, either secondary. So it's
Hmm.
not always for sexual dysfunction, okay, or erectile
Hmm.
dysfunction. That's a important learning point.
Hmm.
The other thing is the age group. We saw, so we said the extremely young age group, we will think about, sexual problem, mental problem, or abuse. All the age group always about complication and complex socio-economic status. The middle age group is a tricky one, especially the patient from 50 to 60. Okay, they are senior, between senior and between middle age.
Hmm.
Usually they are very difficult, to predict them, to be honest. Okay. Can come anything. Yeah, can come sexual abuse, can come multi-complex case scenario, can come suicidal. So it's difficult to predict based on the age. But at least you have in the 3 minutes, you can do some differential regarding headache and dizziness. Yeah. Yeah.
Hmm.
So
Hmm.
you can put in your notes, okay, I can do some differential about headache. Okay, what I will ask about headache. And what is the cause of headache plus dizziness? Is it
Hmm.
vascular? Is it neurological? So all of this you
Hmm.
can write it in your whiteboard and try to predict it. And then going to major problem, yeah, diabetes, hypertension, depression. So he had an annual review. Yeah, he had the annual review. Then that might not be considered in my management plan, but in the annual review, did they miss something? Well, I
Hmm.
guess so. They said some bloods. Does he need to do? We said diabetes, hypertension. You need to do blood and you need to do urine. You might consider that if you have time, for sure. If you have time, you can add the ESR. Please, doctors, if anyone opening his mic, I would be grateful if he can mute himself. Okay, just for discussion purposes, please. So that also you might consider it if you have time. Yes,
Hmm.
Dr. Asya. Yeah.
But in this one, doctor, it's written already that bloods were done 1 month ago and everything is fine and HbA1c is on
Yeah.
target at 51.
Yeah.
So,
But they
mm,
said blood. They didn't say urine
which
as
bloods?
well.
Okay.
Yeah. So bloods. So just
Mm,
take care because sometimes it
mm,
can come.
Mhm.
that they are missing something and you might
Mhm.
need to correct it. If you find time, it will not have a big bulk in the,
Mhm.
in the management, because there will be more important things in
Mhm.
the case scenario.
Mhm.
So I think, yeah, this is all what you need to know. And maybe asking, you for sure you will need to ask about the mental health and how the things gone and what is the problem that happened from before. So
Mhm.
do you feel ready? Shall we start?
Just give me 1 second.
Sure, sure, sure.
Okay. Um. Can Okay, we can start now.
Yeah,
Yes. Hi there. Hello. My name is Dr. Asim. Oh, sorry. I'll start again. Good
yeah,
evening. My name
that's
is Dr.
fine. I
Asim.
will start. Yeah, because hi
Yeah.
there. Last
Hi
time you
there.
say
Yeah,
it
you
was
told me. Yes, exactly. Yeah, no,
good,
we'll start
good,
again.
good. Sure.
Good evening. My
Good
name is
evening.
Dr. Asim. I'm one of the doctors at the surgery. Can I please confirm I'm talking to Jack Mack?
Yeah, it's me, doctor. Yeah, I'm Jack Matt.
Okay, and you're 56 years old? 55 years, sorry.
Yeah, yeah, exactly, exactly.
Okay, so how can I help you today, Jack?
Well, to be honest, doctor, I'm worried. I have this headache that's
Mm-hmm.
lingering around.
Mm-hmm.
I can't get rid of it, and it's
Mm-hmm.
coming in an unpleasant time, to be honest.
Mm-hmm. Okay, can you tell me a bit more about it? How long it's been there and how
Well,
it
it
is
has,
affecting you?
yeah, it has been there for, I think 2 months now.
Mm-hmm. Mm-hmm.
Yeah, and usually when it's come, I don't know how can I get rid of it? Paracetamol, ibuprofen, nothing, nothing is effective, and it's always coming in unpleasant time, to be honest.
Mm-hmm. When you say at an unpleasant time, can you explain that a bit more? What does it mean to you?
Well, surprisingly, doctor, I noticed that my headache is always coming during sex. I'm not
Okay.
sure if it's related, but
Uh-huh.
whenever I had sex with my partner, and I feel I had this headache,
Hmm.
and then also after it, also I have it.
Okay, this is actually quite important information. Can I just ask you a few more questions just to build up more on this?
Yeah, sure, doctor.
So, how long does this headache last, and does it always happen during the sexual activity in the
Oh
last 2 months?
yeah, yeah. It's only coming during sex, to be honest, doctor. Yeah,
Hmm.
and
And what?
usually it will
Yes, please.
last. It will last like 1 or 2 hours after it.
Really? Okay. And with this headache, have you experienced any other symptoms like any nausea, sickness, or vomiting?
No, no,
Nothing at all.
no,
Okay. And do you experience any vision problems when this happens?
no.
Okay. Can you tell me where is the headache centered? Like, is it at the back of the head, at the top of the head, or at the front?
Well, to be honest, it varies, doctor, but I
Mm-hmm.
feel it's more like pulsating one,
Hmm.
usually in the sides, but it
Hmm.
varies, but it's what I can confirm, it's pulsating, doctor.
Is it? Okay.
Mm.
Okay. And it can come on one or the other side, or it's always
No,
one side?
no, it's all over, to be honest, doctor.
All over. Okay. Okay. Fair enough. Do you think this is the worst headache that you've ever had in your life?
No, I don't think so. It's just
Hmm.
boring, It's not the
Hmm.
worst. I had worse than
Hmm.
that. I used to have migraine from before, and
Hmm.
migraine is worse than it.
Hmm. And you don't think this headache is similar to migraine, I imagine, with what you're telling me.
No, no, it's
It
not.
seems different. Hmm.
No, completely different.
Hmm. Hmm. Okay, fair enough. And then you said you take paracetamol, ibuprofen. It doesn't relieve it, and it goes after 2 hours almost. Is that right?
Oh, yeah, doctor. Yeah, it doesn't
Hmm.
relieve
Hmm.
it at all.
Hmm. With this headache, have you noticed any relation in terms of any weakness of the arm or leg that you ever get?
No, no, no weakness,
Okay.
thankfully.
Okay. And do you notice any slurring of your speech?
No,
Okay, and ever noticed a drop in one side of your face at all?
No, no,
Okay, okay, fair enough. Thank you. Okay, just by seeing your medical notes, I see that you do have some medical conditions like diabetes, high blood pressure, and some depression as well. How are you getting on with all of the medications that you are taking?
yeah, it's fine. I'm taking them, as prescribed.
Mm-hmm, mm-hmm. And when did you last have your blood pressure checked, can I ask?
When we had the medication review,
Mm-hmm. Okay,
yeah,
and that was fine? It was normal?
yeah, they told me it's optimum. Yeah, they told me I'm in
Okay,
the target.
okay, fair enough. Have you noticed any fever or any rash on your body at all?
No, no,
And have you noticed any discharge down below, meaning any seminal discharge?
no.
No, nothing at all. Okay, that's fine. And you did discuss about that it comes around sexual intercourse. I might ask you a few sensitive questions if that's
Yeah, sure,
okay.
sure.
Are you in a stable relationship?
Yeah, yeah. I'm married, doctor. Yeah, I'm married.
Okay,
I have a husband.
okay, okay. And how is your relationship like? Are you is he supportive towards you and you're okay?
Yeah, yeah. He's supportive. Yeah, I think
Yes,
he's
okay.
okay. Yeah.
Fair enough, fair enough. And apart from this headache and dizziness, is there anything else that you were concerned about today?
Well, it's just no. It's just doesn't make sense to be honest. And
Hmm,
sometimes I had to stop. To stop the sex because of it.
hmm,
So
hmm, hmm.
yeah.
Okay, I'm sure that must be distressing. And is it impacting you or your partner, do you think?
Well, no, I think our relation is fine.
Hmm,
We had our ups and downs.
hmm,
We was in stress because I discovered that he cheated me once, and then
hmm,
now we are fine. I mean, we go. We pass it. We pass it.
hmm. Sometimes lifestyle factors can also impact on how you feel or your condition. So can I ask, do you smoke?
No, doctor.
And what about alcohol?
No, no, I'm not smoking. I'm not
No.
drinking alcohol.
Okay, fair enough. That's fine. And you said already you're compliant with medication. Is there any
Mhm.
new medication that you started in the last couple of months?
No, no, no,
Mm. Okay,
no,
fair enough.
not me. Not me. I mean,
Uh-huh.
my partner started in medication.
Mm-hmm. Okay, okay, that's fine. Okay, so what is going on in your mind? What do you think that might be contributing to this headache or why it might be happening?
I don't know, doctor, to be honest.
Mm-hmm.
I'm not sure.
Mm-hmm. And is there anything that you were particularly worried about?
It's just because, now I'm trying to avoid sex because of
Hmm.
the headache, and then my
Hmm.
partner maybe he will feel that I'm not loving him anymore. So,
Oh, oh, no, that's and thank you for voicing that, and we can talk more about this. Is there anything else you were hoping for?
no, no, just to
Okay.
make sense of it and try to avoid it.
Hmm. So, Jack, based on what you've told me, I'm a bit concerned hearing this that your headache comes on during sexual intercourse, because this can actually mean there might be a problem with the blood supply in your brain that is causing this to happen. I'm not a
Okay.
100% sure, but I'm concerned this could be something serious, Jack.
Oh, really? Okay.
Hmm. Hmm. Usually, headache which comes on during intercourse and is so intense so as to stop you from intercourse, this does need further investigations, to be honest with you.
Okay.
Uh, has this come as a shock for you, or had you that in mind? Were you thinking about this?
Well, no, it's just, I feel that there is something wrong and,
Hmm.
better to investigate it rather than
Hmm.
ignoring it.
Hmm. I think, to be honest with you, a CT scan of your brain, which is a specialized scan that can look at the blood supply and to look for any problems in terms of the blood supply of the brain, would be a helpful option in this case.
Okay. Yeah.
And
Well,
unfortunately, we can't order it in the primary care. which means going to the hospital would be a better idea.
Okay. Yeah, I don't mind if you feel that this is needed, doctor.
Hmm. I think the best thing would be, Jack, where are you at the moment? Are you at home or are you at work?
No, I'm home.
You're home. Okay. What I would do is I would call the medical assessment unit and I
Mhm,
would take an advice from the medical registrar. And if
mhm.
they are happy, then you can go into the hospital to get all further investigations done. How does that sound?
Yeah, yeah,
And
I'm happy.
possibly a scan.
Yeah, I'm happy. I'm happy to go
Hmm.
if that's necessarily.
Hmm. Hmm. Well, in some cases, headache during sexual intercourse could also mean a subarachnoid hemorrhage. Have you ever heard about this?
No, doctor, no.
Now, these are different things that are coming in my mind, and that's why I feel a CT scan, which is a specialized scan of your brain, would be very helpful. So, this hemorrhage means that sometimes there can be a small, you can say, clot in the brain that can cause this to happen.
Okay, clots.
Hmm.
Okay, mm,
Hmm. Bleed. I would rather say bleed rather than clot, to be honest.
okay. But doctor,
Okay.
if I had a bleed, would it not give me any other symptoms, doctor?
Hmm, that is what is I don't know the answer to that, to be honest with you. And you also said that it goes away after 2 hours, which
Mhm.
in itself is not tells us that the headache is not, to an extent where it doesn't go away. It does go away, which is actually a good thing. But I would still like that it should be investigated further.
Yeah. So, do you think maybe if I come and you examine me, would
Hmm.
that maybe be better, or what you think, doctor?
To be honest, I
Rather
think as
than.
you mentioned, your blood pressure has been fine in the last check and you otherwise feel well in yourself. I think it might waste a bit of time if you come in here. Maybe if I talk to the medical registrar, it would be a better option. And then you also said that you are concerned about obviously your sexual intercourse as well, and your partner might be thinking that it's
Mhm.
related to it. So, of course, I can see all of this can be quite distressing for you. Once you are discharged from the hospital after further workup, we can discuss more about what would be a safer option for you and how you could practice intercourse going forward.
Okay, that's fine. I was wondering, doctor, because my partner started to use that cream for his back passage,
Mm-hmm.
last a
Mm-hmm.
few days, last a
Mm-hmm.
few months,
Hmm.
and we noticed that the headache might be related to that. Would you have any
Okay.
thoughts?
Yeah, sometimes there is a cream that is used. Is there a name to it? Is it a GTN cream at all?
Yeah, I think so because
Hmm.
he had a fissure 1 year ago,
Hmm. Hmm.
and then
Yeah,
I
there
think the
is.
fissure returned again that he started to use it.
That's very important information because yes, that cream can give us effect of headache. Definitely, that is w- one reason it can happen.
So do you still need me to go to the hospital?
Well, to be honest, I would still like you to go to the hospital for further assessment, given your other underlying conditions as well.
Yeah, that's fine, doctor. Yeah, I will go. I will go. Yeah.
That was very difficult. I didn't really
Yeah,
understand all things.
yeah,
Yeah,
because
I just thought sexual
yeah, you
activity and
missed the
then,
cue, but
headache. I was like thinking of SAH and things
yeah,
like that.
but you did it well for the subarachnoid hemorrhage. But the
Yeah.
problem is, and this is the problem, okay, the people will
Hmm.
think that they did fine in the exam, and then
Hmm.
the story is completely different, okay? And
Hmm.
it's only subtle cues, very subtle cues. And then I give you the clue in the beginning. I told you, please use every. Did you use this? You didn't use it at all. And the problem solving, yes. So the patient already told, it's already written that there is the constipation. The patient have guilt that he did something to his partner, and the partner will have the operation and he doesn't feel that there is a problem. So I didn't hear you inquiry a little bit more about that, did you, Asra?
Mm, No, no, you're right. Actually, I didn't quite understand these three lines, to be honest with you. So I didn't know how to ask this or inculcate it in the history. So that was another problem because I
Well, you
wasn't.
can. Once he told you, "I have a husband," okay, so
Hmm.
just always with the sexual minority cases, okay, especially men's having sex with men, you
Hmm.
need to check, their sexual health. You need to check if they have any, mental health issues. You need to check if there
Hmm.
is any abuse, because these
Hmm.
are the common presentation of that, that type of patient. Okay, and
Hmm.
if you read any guidance regarding, men having sex with men, they will always telling you, please check their how many times they're having their and annual sex checkup, okay, the swabs, and going to the gum clinic how many times a year, and their vaccination, and their mental health, okay, and clearly you can see, even I put here with bold. I never use bolding, and when I'm writing the cases, but I use that here: address mental health concern and relation problems. So yeah, so I think you missed this queue, which is in the data, already in the the queues can be already, before talking to the patient, you might have some cues
Hmm.
even in the written, okay, in the written case scenario. And then when I start to talk with you, I already give you some cues. Well, I told you I have a husband. Okay, so this means that the patient is not straight. Okay, even I didn't tell you a partner. I tried to make it more clear, a husband. And then when you asked me about did you start any medication, and then I told you it's not me, but my husband starts a new medication. So
Hmm.
I think here where you missed the cues, because it was just before you start your management plan. I'm not
Hmm.
sure. Did you
Hmm.
hear it?
Actually, the thing is, yeah, I actually heard it and I
Mm.
wanted to explore it, but I thought I had only 5 minutes left already for
Yeah,
management. So I'm
yeah,
not sure if that would
yeah,
be relevant information to dig it more or not.
yeah, yeah. Well, be sure if case like that appear in the exam, the actor will try to help you, because it's not an easy case. Okay,
Hmm. It
and
was
and
difficult,
and
yeah.
especially if it started for the first time to appear in the exam.
Hmm.
They will try to help you, okay, because it's difficult, it's tricky, and you will find it in that, real life. You will face it in the real life, and we will face it in multiple case scenarios, which we will discuss how it can, how you can find it in real life. But let's talk about what you did fine, or what you think you did fine in this case, because the most important thing that you remember what my advice of the last week, and that's what, I'm happy with that, that you remember. So you learned something from the last week. So what else you think you did it fine?
I think I checked the compliance with medications. Data gathering was okay in terms of the headache, to determine the shock rates and also to see that, whether it has any relation with any new medication. He was checking, although I didn't take the partner's medication in account. But I checked kind of the, how's the partner, is he supportive? But I didn't check the mental health bit. Smoking and alcohol, so lifestyle changes I kind of asked. And then I think data gathering wise, I might be okay. The main thing was the management because I didn't pick up on the cue, so I couldn't reach the right thing.
Yeah, well, that's right. But I need to tell you some few information about the subarachnoid then, okay? Because you
Mm,
consider it as a subarachnoid. So yeah,
mm,
subarachnoid usually, yeah, if it comes, the worst case, headache, but can sometimes trick a little bit, or the aneurysm, if is there an aneurysm, can sometimes blow out, increase in size and then decrease with the vasodilatation of the Viagra, and that will come and come little bit, and then the pain will resolve, come, and the pain will resolve, but then suddenly when it's ruptured, then the pain will be persistent. So usually it's difficult that if you have subarachnoid hemorrhage, that you will, it will resolve by its own. Okay, very difficult. This is one. The other thing, you will have sign of, meningismus, isn't it? So if you have blood in the subarachnoid space, that will give meningeal irritation. So you will have query meningitis sign. So bringing that patient and examining him, to be honest, will be optimum, rather than just sending him to do CT scan and sending him to the internal medicine people, which usually they will not also be able to do much for him. And I will explain why. So bringing him in and checking his blood pressure and checking the meningeal irritation sign is important, to be honest. Um, is that clear up till now? Because I didn't, yeah, you
Yes,
said,
yes.
yeah, because I heard from you blurred vision, but I didn't hear, photophobia. I didn't hear neck irritation and neck pain, which is
Hmm.
important if you are worried about subarachnoid hemorrhage, isn't it?
Hmm.
The
Hmm.
other differential was fine, was okay. You said about rash. I think the rash because you was worried about meningitis, perhaps, and
Hmm.
fever.
Hmm.
You said about nausea and vomiting. So nausea and vomiting is related to an increased intracranial pressure, but
Hmm.
also you might add also if is the pain of the headache nature or pain is increasing or changing in the position it change. So if you have an
Hmm.
intracranial pressure increase, like a tumor or bleed, so if you lie down, the headache will increase. Okay, if you cough, the headache will increase. If you sneeze, the headache will increase because the intracranial pressure will
Hmm.
increase. Okay,
Hmm.
and then if you sit up, okay, or become upright position, the intracranial pressure will decrease because the venous return to the brain will decrease, okay, and that will make the intracranial pressure less. And then one of the main, if someone work in the ITU or work in the emergency, if you have an intracranial bleed, one of the main treatments that you need to put the head of the bed for 45 degree. Beside for sure the perpetuate coma, and it's not, I mean, it's not one of the things that you need to know now, because that's more for the emergency physicians. But this one of the things that you might consider asking the patient is if the pain of the headache or the headache is worsening with your position. This is one of the red flags of the headache. So that's also need to be put it in your differential and your questioning. Is that fine? Yeah.
Yes,
Yeah.
yes, exactly.
So what else you want to ask? So, yeah, he already have, he have experience with the migraine, so I already tried to block this for you, so not to waste your time. And then you ask about spice, there was the ice and the psychosocial fine, except that you didn't explore more about the relationship, okay? Um, so try always, as we said, connect what is given in the sheet with
Hmm.
the with the management plan and the questioning. Okay. So if you ask
Hmm.
that man, or if you ask that man, then he will tell yes, he is married to, So if for example you now got the queue, okay, and you know that now he is married, and then whenever he have intercourse, he will start to have this headache. So what are sort of questioning you want to ask? Just because it's important and it's not familiar for us, unfortunately. What we need to
Hmm.
ask in regards of the SMS or your men's having sex with men's. So what you will need to ask, what will be important to formulate your management plan. And then we will go through the management of the subarachnoid hemorrhage, and then or subarachnoid suspicious of subarachnoid hemorrhage. Then we will go through the detailed management of if a case of men's having sex with men's appear in the exam. So what sort of questioning you will ask him?
Well, I think condom use because it can
Okay.
prevent the sexually transmitted
Yeah.
infections.
Yeah.
Then
Definitely,
obviously,
especially what he told you, because
mm,
I also give you another cue in between that I want you to ask about these things. What he told you,
mm,
he told you I discovered that he was cheating me, but now we bypassed that. Then
oh, I
you
didn't actually.
remember? Yeah,
Yeah, I was
yeah,
trying to listen as to what you used the word, but I didn't
yeah.
get the cheating word.
No,
Okay,
yeah,
then
I
fine.
don't know he is cheating me, but then
Uh,
but we bypass that. So that means
uh,
that you need to formulate some, sexual advice in your management, condom
hmm,
use,
hmm,
going to gum clinic either annually, and
hmm,
we will discuss that because men having
hmm,
sex with men, they should have, if they are even if they are using condom, even if they are
Mm,
having safe sex, they need to do annual check, okay,
mm,
for HIV, hepatitis B, hepatitis C, syphilis.
mm,
So that's one of the things that you need to emphasize for the patient. Maybe he don't know,
mm,
but
mm,
then if someone is cheating the other, then the frequency will increase. So the guidance is saying either every 3 months, either every 6 months, that they
mm,
need to check the HIV status and. Okay.
mm.
Yeah.
Okay.
What else? What else?
Other than that, I think we can check whether they had HPV vaccination or thing when
Yeah.
they were younger. Yeah, I think that would be relevant.
No, no, yeah. So if they are above lower than 45 years, then HPV vaccination, hepatitis B, hepatitis A,
Mm,
and meningococcal vaccine. These are indicated with these four vaccines. They must take
mm,
it. Okay.
mm, mm.
What else?
And I think then other things could be obviously things like, any anal irritation, any, kind of anal pain or anal symptoms. I think possibly that would be relevant as well.
Yeah, yeah, but
Bleeding from the
that's
anal
right.
cavity.
But
Mm,
then, yeah, that's right. But then you need to know who is the receptive and who is the giver. It's
mm,
important.
mm, mm,
And what type of sex that they are practicing, okay? Because
mm.
according to, not because you want to be nosy and to listen what they are doing, uh, because it's important in and first, if you want to do swaps, what swaps you want to do.
Okay.
Second things, also the risk assessment. So risk assessment of sexually transmitted disease. So according to the studies, they find that the anal receptive patients, they are having higher incidence of having HIV and sexually transmitted disease,
Mm,
because this is how, this area was created. Well, it's created for, stool passages. It doesn't have a lot of IgA sort of protection, but normal vagina, they have, acidic in nature. Normal vagina have IgA and a lot of IgA antibodies. So if there's any viruses or bacteria, then there is a sort of protection there that can prevent the infection from spreading. But this area is, was not created for that. However, so they are having more, and also during the intercourse, the fissuring and the traumatizing of the external anal sphincter or internal anal sphincter will make the spread of infection more easier. So that's important. That's why we are asking, okay, because you need to do risk assessment. What else you think we need to ask?
not sure what else.
Um, we need to ask also about if they are using illicit drugs, okay? Because they find that a lot of people having male having sex with males, they're using what is called amyl nitrate. I'm not sure if any of the doctors here heard about amyl nitrate as illicit drugs and what the amyl nitrate is doing. Is anyone
Is
can
it like
participate?
copper pill?
Is like what, sir?
Copper pill, like
Yeah,
with
exactly. Yeah, yeah, gold dust. Yeah, 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 pepper. Yeah. So why would they are using it and what? Do you
I
know?
mean, to dilate the anus to have like painless anal sex.
Exactly, exactly. It's a sky high drug. Okay, for it will make you, it will make your brain high. Okay, so as well as it make all the smooth muscles to be relaxed. Okay, and one of they are using it to make the anal sphincter relax, and also it's used in sex industry with the female. Do you know anyone know why in the sex industry the females can use it in case if for example prostitutes appear in the exam or something. So do you know anyone know why the female are using it in the sex industry? I'm so sorry. It's
Multiple
just
site
it's
penetration.
yeah, exactly,
Multiple site
exactly.
penetration.
Yeah, exactly. So they are using it also for the vagina to relax for multiple penetration. Okay, and also that's a contraindication to use the Viagra with. Okay, because if the patient, say male, and he is receptive and as well as giver, and he used the amyl nitrate and at the same time he used the Viagra, his blood pressure will drop. He can have an MI because of that. Did anyone know why the Viagra and the nitrates are contraindicated to be taken together?
Because they cause profound hypotension, because
Yeah,
both have vasodilator, because of the profound vasodilator activity.
yeah, that's completely right. And the problem is not only vasodilatation, it's causing the uh, coronary perfusion pressure to drop. Okay, we know that the coronary filling is happening in the diastole. So if the venous return is low and the heart is, pumping, rapidly, so the refilling of the coronaries will be low, and then that will precipitate ischemia. Okay, so that's very important to know, and we will know when we should have and when we should not have it. So, the Viagra is different than Cialis. Okay, Cialis is long acting. Okay, and can stay up to 48 hours in the body, but the Viagra is short acting. So yeah, I think that so the GTN spray and the Viagra, the difference between them around 12 hours, but the Cialis you need to take care 48 hours. And if a patient have a chest pain after having Viagra or any of the PED5 inhibitors, he can't take GTN. He needs to go to the hospital because if he take GTN spray, he will die. Um, yeah, so that's regarding what you need to ask. So coming to the management, so coming to the management for your subarachnoid hemorrhage. So do you know the timeline of subarachnoid hemorrhage and when it will appear in the CT scan? Isra?
Is it up
No,
to 8 to 12 hours?
No, well, yeah, 6 to 12 hours can be, but again, it's very difficult. So, the most sensitive
And that's what
methodology,
a
the
lump
most
puncture after 12 hours.
lumbar puncture and seeing if there's have xanthochromia or not. This is the most sensitive. With the new modalities of MRI, I think, but the issue is the MRI is not available in every trust. So the MRI will be also sensitive in such instance, except especially if it's the high, the fourth or the fifth generation MRIs. So we'll be able to detect the hemorrhage, okay, of the subarachnoid. But depending on the CT alone, to completely diagnose subarachnoid hemorrhage, bit tricky. And if this patient come to me, for example, and he have persistent headache after 6, I will be a little bit cautious to depend only on the CT scan. Usually, these patients, they will admit them, then they will keep them under observation if we think it's a subarachnoid hemorrhage. Um, and then just regarding the time management. Well, management, you start your management at 4:30. I think explanation wise, I mean, is late little bit, but based on the complexity of the case, I would consider it fine, no problem. And then explanation wise, for the subarachnoid, I would bring him in. I would bring him and examine him, check his blood pressure before
okay.
just sending him to the hospital. Okay, because on which basis I will call the medical on call, registrar and start to discuss the case with him, and I didn't do any examination. It's um, not ideal, not ideal. If you
Mm,
can see him in
mm,
the same day and then refer, because it will not make a big difference in his management. Okay, they themselves will not do an instant management or a treatment plan for him, even if he was in the hospital. Um, Perhaps when he come and do the examination, you will find something else. Okay, rather than just sending him. But explanation wise is fine, subarachnoid. But just about clot and blood, I'm not sure when you explain the subarachnoid hemorrhage. Can you explain it now for us, please? No. So what you were saying, subarachnoid
Yeah,
hemorrhage.
actually,
So
that time I couldn't explain it well. I think we can call it as it's a kind of a bleed under one of the coverings of the brain.
yeah, yeah, it can be. Yeah, or bleed in the brain. That's fine. Okay. He might tell you why, doctor, why I have this bleed. So tell him that that sometimes you have weakness in your bloods vessels, okay, that is supplying your brain, and that can make the rupture. And usually subarachnoid hemorrhage, if they aneurysm, usually you need to ask about the family history. This is something that
Mm-hmm.
you might need to consider it, because aneurysm is usually running in the family. Okay, or if the patient have family of polycystic kidney disease or something. So these things also you might consider it in the questioning if you think that this is a subarachnoid hemorrhage. Just do you know what they will do in the hospital if this is subarachnoid hemorrhage? Do you know? That's right.
Not really. No, we always
So
pass it on to
yeah,
this
yeah, well,
bleed and then.
usually it will do MRI angiogram, okay, and then according to if he have aneurysm, where is the aneurysm, and the size of the aneurysm. Usually we are also writing some, for the acute management, we are writing calcium channel blocker, okay, we are writing nifedipine or uh, to prevent the secondary vasospasm of the vessels, because if you have an subarachnoid hemorrhage, the body will reflect by constricting the vessels to prevent the bleeding, okay, from progression, and that can cause ischemia to the brain, okay. So, and also the continuous bleeding can cause later on what SIAD syndrome. So we need to always to check their, electrolytes, and check their kidney function,
Mm-hmm.
and give them the calcium channel blockers. Um, we are not tend to give
But
him
if it is due to
anticonvulsant.
an
Yeah,
aneurysm, then if it is due to an aneurysm, then they do clipping or coiling,
clipping.
isn't it?
Yeah, yeah,
Yeah.
clipping. Now it's coiling, to be honest, because clipping is out of fashion. Okay, except if it's very huge aneurysm. Okay, and if a huge aneurysm, most probably you will die before reaching the hospital, because once it bleeds, it will never stop. So usually the small aneurysm, you will do coiling. Okay, yeah, coiling is now on fashion, and because coiling is just an intervention radiology. Okay, but without opening, without microsurgery. Okay, or catheter, go to the brain, put the coil. The coil will just make the aneurysm to collapse. Is that clear for the subarachnoid? Yeah, I hope
Yes,
so.
yes,
Yeah, and for
yes.
sure, optimum control to the blood pressure. You might consider stopping the mirtazapine in the acute, setting, because that can increase the intracranial bleed. Atorvastatin also, okay, because atorvastatin, one of the tablets that increase the intracranial bleeding, okay, and actually, atorvastatin contraindication is intracranial hemorrhage. If the patient have previous intracranial hemorrhage, so please, 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 if you have a patient having intracranial hemorrhage and was discharged to the community, and then you find the cure risk is high and you want to start him in a statin, you need to double check your decision. Okay, and I would prefer first to consult, to speak with the secondary care consultant before starting something like that, because one of the contraindication of the statins is intracranial bleed or previous intracranial bleed. So atorvastatin can increase, or statin in general can increase the intracranial hemorrhage risk. So I think this is maybe new information for you, guys, doctors. Yeah. So just double check it. Yeah, don't run for statin when the patient have a previous history of intracranial bleed. And we know SSRIs, all SSRIs or atypical antidepressants, they're like mirtazapine, having higher incidence of bleed as well. So you might do some these modification in the medication if the case is subarachnoid hemorrhage. Coming back to patient, males having sex with, there is some definition. Okay, I need to go through them because this definition is sometimes confusing. Okay, we need to know them. Okay, for your general knowledge, and if you met some of the patients. with different belief or thoughts. So generally, sex is what is the chromosomal determinant of your, of your cells is, and then gender is what your personal feeling is. Okay. Um, cisgender is the when your personal feeling and when your chromosomal sex are the same. Okay, so that's mean they are straight male or straight female. Okay, so coming to transgender when your chromosomal, determinant is different than what you feel, okay, and you want to change your gender. And here is the trick, okay. So Asma, if you have a patient, he said to you he's trans male. Do you get it? What trans male mean? Asra?
Yes, yes.
So what does it mean, trans male?
So, who was born as a female but who
Yeah.
wants to change, like who has characteristics or identifies himself as a male.
Okay. And then what is the trick in that? When he said that I'm trans male.
Hmm.
So if it
The,
came to you as a case,
yeah.
it's trans male. So
Hmm.
what you will consider as a trick you might fail in it.
The main thing is that obviously they have a uterus, so you have to make sure that they have cervical screening and.
Exactly. So,
Hmm.
exactly. So the problem
Hmm.
is when it's trans male. So what is sometimes he can be trans male, but he will present for you as a female, exactly with everything
Hmm.
intact. So it
Hmm.
depends. It depends. Did he or did he did an operation? Okay, for
Hmm.
transformation. Did he
Hmm.
start to have gender affirming hormonal treatment or not? So you
Hmm.
need to ask that. So did he did mastectomy, or if he did mastectomy, did he did hysterectomy, and what about the
Hmm.
ovaries, and what about the vagina? Because
Hmm.
if these are present, they still need to have cervical screening.
Yes,
Okay,
and
they might have
contraception, etc. etc.
contraception, exactly,
Hmm.
and they might
Hmm.
have ovarian cancer, and they might have vaginal problems. So that's a trick. And the opposite is if it's trans female,
Hmm.
then you need to make sure that is she still having her penis, is she still having her testicles or not, or she's still having her prostate, because she can be trans female and even remove her testicle or his testicle and his penis, and he keep his prostate, and then he can have a prostate cancer, or she
Hmm.
can have a prostate cancer, and and later in life. So these are why these cases, if present in the exam or in the real life, are tricky. So you need to confirm what they did. And the other thing also, when you are talking with them, you need to ask them what's pronoun they like. Okay, so
Yes.
so once I was talking with someone, I'm saying he or she, and then the reply was very, sharp from them. He said, I need to be called by they or them. So it's always before, if you met any one of the transgenders, just make sure what pronoun they want you to use. Okay. And the other thing, if they are taking hormonal therapy, you need to make sure if they are having any side effects of the hormonal therapy, if they have any contraindication of the hormonal therapy, and who prescribe it. Okay, because a lot of them can get their hormonal replacement or hormonal therapy over online. Okay, so you need to know from where they are getting it and if they are safely using it or not. And then the other type of gender was called non-binary, which is, non-binary mean that he doesn't or she doesn't or they doesn't consider themselves either male or female, or they don't want to be assigned to a sex. Okay. And these people also might still having, hormonal treatment for a hormonal blocking agent. So also you need to ask that. So you have either estrogens, either progesterone or female sex hormones that you can have them, or they can have testosterone, okay, and as well as six hormone blocking agent, so which usually used by the non-binary. And then assigned male at birth and assigned female at birth, which is your chromosomal gender. Then then classification of the patient according to his or his sexual desire. So straight, which is man having sex with female, or the male having sex, or female having sex with male. So the opposite sex, which is the straight, the normal. And then gay, it's a prescription for both, either man having sex with man or female having sex with female. Okay, which in the late term, female having sex with male is lesbian, and then bisexual mean that the patient have sex with either genders. Okay, male or females. Okay, pansexual mean that it doesn't matter which sex in front of him. He doesn't care about sex. He might have sex with bisexual, or have sex with binary. So that's called bisexual, pansexuals. And that's why the term of men having sex with men, because it's not all of the men having sex with men are gays. Sometimes they can be bisexual, and that's why to avoid confusion, the terminology of men having sex with men appears. And why men having sex with men is important to know, because according to the studies, the STIs are is the highest among this age, this groups. Okay, so young heterosexuals, okay, black ethnic minority, and men's having sex with men's. And the other thing, when I said that it's important to know what is the mode of sex that they are having, because according also to the studies, we can see that the receptive anal intercourse, the HIV transmission is 3% of it. What is the health belief, or what is the advices that you need to give it to such a case presentation or patient presentation? Is the pre-exposure and post-exposure prophylaxis. Okay, so who is indicated for, and what does it mean? So the pre-exposure prophylaxis, so every patient have negative HIV. Pre and post-exposure is usually related to HIV. Okay, hepatitis C, there is no pre or post-exposure. Hepatitis C, if you have it, you need to be treated. Unfortunately, there is no still pre-exposure prophylaxis to it, or post. And then, as well as hepatitis B, we have post-exposure or vaccination. Okay, thankfully, all of us as health professional, we need to be vaccinated for hepatitis B. And then, in case if you are not vaccinated, then there is the fast acceleration, vaccines, 3 shots, and as well as the immunoglobulins. Okay, so that can present as a case of unprotected sex, okay, exposure, or even as a health professional, or having needle stick injury, or for example, patient was in the garden, and he was a public garden, and then sometimes they're using the public garden for needling or taking drugs, and then when the patient was walking or something, he had a needle stick injury, and he's presenting you to your clinic. Then what you will do and what you should advise him. Okay, and which is the post-exposure prophylaxis. This is the importance of knowing the post-exposure prophylaxis. Keeping in mind that if a patient was have accidental injection, for example, in the garden, and it's always advisable if the patient can bring the needle with him. Okay, because it depends. Is it clean needle? Is it not clean needle? Is it blunt or penetrating needle? And usually, if the blood is dry, okay, and he had and he had accidentally prick himself with, it's less likely that any infection will be transmitted to him. But in such case scenario, always advise you try to call the on-call microbiologist, okay, and take his advices and be guided by him, okay, in real life, and also in the exam. Coming back to the sexual pre-exposure prophylaxis, when it's indicated, and what are the numbers that we need to know. So it is indicated if patient have HIV, and he knows that he will have intercourse, he will have sexual activity with patient that having HIV, or having intercourse that it's not protected without condom. Okay, and you can use it either on demand, pre-exposure prophylaxis, or continuous, and we'll see what is the difference between them. The other thing, what does it mean high risk or low risk transmission of infection? So if a patient have HIV and he's treated for HIV for 6 months, continuous or more than 6 months of continuous treatment, and the viral load in most of the recent study less than 1,000 replicant per mil. Okay, so that's considered low risk. Okay, from few years it was less than 200 replicate per mil, not 1,000. But recently they changed it, I think, because of that the antiretroviral treatment are more effective now. Um, so what are the indication of pre-exposure prophylaxis? So men having sex with men, okay, or heterosexual with high sex group, or trans individual with certain, sexual exposure, or even or yeah, these are the most important indications for the pre-exposure. And then when the pre-exposure prophylaxis should be effective, okay, it should be effective within 24 hours, okay, or sometimes if you have a vaginal intercourse, it should take at least 7 days to be effective. And it's the same as the post-exposure prophylaxis Truvada. So if anyone was working in the emergency department, we have packs of Truvada on the emergency, where we are giving it to the patient, after needle stick injury, or even a colleague if you have needle stick injury. Keeping in mind that you need to know what is the possible side effects of the post-exposure prophylaxis or pre-exposure
Uh,
prophylaxis.
Dr.
Yeah,
Salim, can you show the slide of indications again for the
yeah,
pre-exposure
sure.
prophylaxis, please?
Yeah, sure.
Okay.
Um, you don't need to know it in detail, because usually if it's appear, it will be men having sex with men. The rest
Okay.
will be difficult, to appear. I think mostly it will appear with men, and I can share this slide later on in the group if you would like.
Mm-hmm.
I don't
Okay.
mind. I don't mind.
So, for example, in this case that we did,
Mhm,
if this man
mhm.
said that they are not practicing safe sex, so should they be offered pre-exposure prophylaxis then?
Yeah, you will tell him, you will advise him about the
Mm-hmm.
pre-exposure prophylaxis, and you will advise him, if he's going to the gum clinic or not. Okay,
Okay.
but for such age group, well, there is no HIV. Yeah, no one of them have HIV. But are using, condomless sex or not? Then that's, if they are using condomless sex and one of them cheating on the other, then yes, they need to have a pre-exposure prophylaxis then.
Okay.
Unless if both of them have, they have they pass the window for the infection from the last intercourse with the third person, which is around 6 months. And then if they did the HIV testing and both of them are negative, then there is no need for the pre-exposure prophylaxis. There's 6 month windows for any, for hepatitis C and HIV, isn't it?
Yes.
For the seroconversion. So if they pass it and then they did the test and both of them are negative, then there is no need for the pre-exposure prophylaxis, except if one of them is planning to keep cheating on the other. Okay. Uh, yeah, then the pre and post exposure prophylaxis, both of them have the same side effects. So they can cause renal, and that's important even if you have a patient having an HIV in your practice, because these are the things that you need, to look after it. Okay, you need to look after his kidney function, liver function, and his bone. Okay, because they are high risk, they have a high risk of osteoporosis. Okay, and also the nausea, vomiting, and headache. Keeping in mind that pre-exposure and post-exposure prophylaxis is safe for pregnant lady and breastfeeding if the cases are becoming more complicated. These are the difference between the pre and post-exposure prophylaxis. And then the pre-exposure, we're using it 24 hours before and then 48 hours after. For the, if you had a patient and, for example, you don't want to go to the gum clinic to have the pre-exposure prophylaxis, there is this website, okay, where you can advise him for, and then they will find the website will, according to your postcode, will show you where the other clinics that can provide you with the pre-exposure prophylaxis. Because a lot of patients would prefer to take it privately. I'm not sure why, but what I meet in my practice that most of them are happy to take it privately. Um, okay. And then the post-exposure prophylaxis is for 28 days. Okay. Keeping in mind that the pre-exposure prophylaxis also can be on daily basis. So if patient, for example, work in sex industry or having always high, high sex behaviors, then he might keep considering taking the pre-exposure prophylaxis in daily basis. Indication of the post-exposure prophylaxis following sex, okay, following needle injury, okay, or splash of mucosa in your eye, for example, if you are doing, surgery, for example, in the hospital, and then you was not wearing your mask, was not wearing your goggles in the eye, and then that this patient have an HIV and some of the bloods enter to your eyes, so that's one of the indication of post-exposure prophylaxis. Also human bites, okay, but it need to be deep bites, okay, that's an indication of post-exposure prophylaxis. And sharing needles, okay. Keep in mind, if the needle is dry, most probably you don't need to have it, because the risk factor, the side effects will be more than probably the benefit. Like, yeah, same side effects, same, rhabdomyolysis as well, and myopathy, one of the, of the side effects of the post-exposure and pre-exposure prophylaxis. We said the hepatitis B is only the immunoglobulins plus the hepatitis B vaccines, okay, and then the follow-up of needle injury or post or of rape or exposed to unsafe sex is 6 weeks, 3 months, and then 6 months. This where you can cover the window of seroconversion. We said hepatitis C only treatment. Not a current practice in the UK, but you might find it, I mean, under NHS, you might find it on private sector, okay, that antibiotic prophylaxis as post-exposure prophylaxis for, sexual activity. They are giving one dose of doxycycline, okay, 200 milligram, okay, within 72 hours after, in any oral or vaginal or anal sex. That will protect against chlamydia and syphilis, okay, not gonorrhea, not mycoplasma, not viral infection for sure. But why it's not under NHS? Because the NHS is worried about, appearance of the resistance. Okay, so they prefer to keep it for, the cases that are already infected, rather than to have, resistance, strains, and then we don't know how we will treat after that. What are the tests that should be done annually if the patient, if for males having sex with males, okay, or less frequently, we say it can be 3 months or every 6 months if they are doing, condomless sex or having, higher sexual behaviors, is HIV, syphilis, chlamydia, gonorrhea, and then the chlamydia and the gonorrhea, it depends according the type of sex, okay, either if it's, if he's giver, so he will need to have benign, secretion or benign swab. If he's receiver, he will need to have a back passage swab, and if they have an oral sex, then they need to have an oral swab. Here, there is an important question. I want if maybe Asra or anyone can answer me. So, if you have a patient that have chlamydia positive, is it indicated to do a test of cure or not? Any doctor can answer that, please? Or Isra, if Isra there. Ruhan,
No,
maybe?
yeah,
For whom?
yeah, you
Yeah.
need to do it. The thing is, you need to do a test of cure if it is, I think, if it is a recurrent chlamydias, because uh, uh,
No.
just that's what I understand, but I may be
Okay.
wrong.
I
Uh,
I
think
think,
the
yeah, go
yeah,
on.
yeah, go ahead.
and
Yeah.
it,
Who want to answer? Yeah. So
Yeah, I
Ruhan said
think,
if it's recurrent, but who have
yeah,
other opinion? Yeah.
yeah, I think there is no need for test of cure unless the patient is under 25 or pregnant.
Yeah, but you know why?
Because under 25 is at risk of getting
Recurrent.
recurrent infection.
Yeah. So do you know when you should do it?
After the treatment, I think 6 weeks. Oh, not sure exactly.
Okay. So it's usually from 3 to 6 months. Okay.
Mm.
If it's vaginal infection, okay, or normal benign infection, but then if the patient have a, because might appear like chlamydia from a patient that who is a gay, for example. If they have an anal chlamydia or oral chlamydia, then the test of cure should be done after a month, okay? Because the reinfection is higher in these areas, okay? This is an important also point, and yes, if it's less than 25, because 25, they find that the age group less than 25, they have multiple sexual activity, so the recurrence rate is high. Okay, that's why they said it's from 3 to 6 months. But for example, if she's a female and she's working, this is her work, for example, or male that's his work. Okay, working in the sex industry. So these people are having sexual screening every 3 months. Okay, otherwise they will not take the permission. Okay, they are taking, these people are taking permission for work. So the permit to work, one of the prerequisite of it, that they need to do their sexual screening every 3 or 6 months. Okay, in the UK is every 3 months. So that's also important to know. So the vaccination, we said hepatitis B, and HIV and meningococcal vaccine, and have a human papilloma virus, especially if they are 45 and younger. Okay, then important part here, which also can appear as problem solving. Patient having HIV and he don't want to say to his wife, or then we need to know that that can be medical legal consequences. Okay, and the medical legal consequences is only depending if you in the UK is different than Scotland. Okay, Scotland's not in the UK. I mean, in the England, Wales, and North Ireland is different than Scotland. Okay, so criminalization of HIV in England and Wales and North Ireland depends on the transmission. If you cause transmission to the patient, then he can accuse you, and there is four prerequisite for that. We'll see them in the next slide. But in Scotland, no, if only if you, even if you didn't cause him transmission, even if you put him in the risk of exposure, and that's called reckless exposure and reckless transmission. Okay, so when you are talking with a patient, say he don't want to say to his partner that he have an HIV, you might use this piece of information and trying to convince him. Okay, so there is no legal obligation to disclose his HIV status, but if he caused the transmission to that patient, he might be put in jail. Okay, so it's always better to open up and tell your partner that you have it or you don't have it. Okay, a person may be charged for if their sexual partner acquired HIV through condomless sex without HIV status have been discussed. Nevertheless, there is no legal obligation to disclose the HIV status or to use a specific prevention method as long as transmission doesn't occur. And that's not in Scotland, I think. It's only in England and the other part of the UK. The term in law, what does it mean? Reckless transmission. So in England, Wales, and North Ireland, it is possible that you can be legally actioned taken against you if all apply. Okay, if you are suspected or known to have HIV positive, or plus if you are suspected or known to have detectable viral load, okay, and we already discussed what is detectable viral load is, and you still have sex without condom, without telling your sexual partner about your HIV status, and your partner acquired the HIV as a result of that. Reckless exposure is in Scotland, which which you are just, you have HIV and you're having, you didn't tell your partner and you are having sex with him, even if he doesn't have the HIV from you. Just exposing him to that risk, he can follow you, in the court. Okay, amyl nitrate or pooper, okay, was take his fame in 1980s. Okay, and we discuss for what it's used. Okay, it's used to relax the anal sphincter or the vaginal, muscles to go for multiple, either for anal sex or for multiple penetration. Coming to some question regarding the Viagra and the GTN and mononitrate. So mononitrate and isosorbide dinitrate with sildenafil or Viagra or any, or any of the erectile dysfunction treatment is no until you take the advice of the cardiologist and see what he will say. Okay, because mononitrate and dinitrate are long-acting drugs. Okay, they are always there in your blood. So once you put the Viagra in your blood, you will have severe vasodilating effect. For the people who's using the GTN, so Viagra and then the Levitra can be used within 24 hours from the last spray, but Cialis should be after 48 hours from the spray. Okay. If you got chest pain after taking these tablets, you will need to go to the hospital. And then when if you have an MI or heart attack, when you can start having, taking the Viagra. So if you don't have chest pain or no, and your condition is stable for 6 months, then you might consider, having the Viagra, provided that you are not taking long-acting nitrate for sure. Okay. Um, the other question will be then if you have an MI, doctor, so if you have a patient with MI and then he wants to have sex, okay, so when you will be able to tell him, yeah, you can have sex?
4
Is anyone?
weeks? Isn't it 4 weeks?
Yeah. Well, in general, 4 weeks, okay, but and more specific when he feel that he's able to do, to have sex, okay, and the definition of that, if he's able to climb 2 stairs without problem, or he is able to walk a mile in 20 minutes, okay, and because still after 4 weeks, he might be still having complication from from the operation or from the MI. Okay, he might have aneurysm, or he might have rupture aneurysm, heart rupture aneurysm, and any strain can make the aneurysm increase or make the leakage of blood. So it depends, but in general, 4 weeks. Okay, if it came, question, sometimes the actor will throw you with some questions. So if say 4 weeks, or you can walk in a flat mile in 20 minutes. Okay, or climb 2 flight of stairs comfortably. Sophia, do you want any questions, Sophia? Was raising
Yes,
your
yeah,
hand? Yeah.
yes, yeah. It's just wanted to ask, like, if someone has got hypertension and they are on antihypertensives, uh,
Mhm.
if you give sildenafil or Viagra, will it be a risk to them of
Yeah,
hypertension or?
yeah, depends on the type of antihypertensive. Okay, if it's alpha blockers, and there is risk that they will get hypotension, not severe hypotension that they will die. Okay, but there is a risk that they will get, they will become hypotensive and can be symptomatic. Okay, so you can just try to, to give them the lowest possible dose. Okay, the Viagra, you can have 25 milligrams. So you can, even the 25 milligrams, they can, split it. So try to start with the lowest, possible dose, and then upgrade it according to the response and how they will be. And if they have if they have hypotension, then they need to raise their legs, and lie flat, raise your legs, and call the ambulance. He need to
Okay.
know, but it will
Thank you.
not be to the degree that they will have a MI. Okay.
Okay.
But alpha blockers also, alpha blocker including, doxycycline, and if he is in BPH and he's using tamsulosin or other alpha blockers for BPH. So yeah, there is some, some interaction between both of them, because alpha blocker mainly acting on the veins, okay, as well as then the phosphodiesterase inhibitors. Here, just, if a patient have sexual dysfunction and appeared, for example, in the exam, and he's wanted Viagra and the Viagra is contraindicated, and you want to give him some other options. So Viagra or alprazolam, which is prostaglandin, can be either creams, which GPs can prescribe it, or intravesical or intracorporeal injection, vacuums, as well as, intrabenile benile devices, okay, which need a for sure operation. And recently, using the microwave shock for the penis, which will increase the blood supply and the fluidity of the bloods in the penis. Okay, so coming to anal fissure, because this was one of the presentation that appears for people who's having anal intercourse. Okay, so anal fissure can be acute or chronic. Okay, acute mean that less than 6 weeks. Okay, chronic more than 6 weeks, and can be primary and secondary. And here is the trick on it. Okay, so if primary, then no obvious cause. Secondary mean there isn't a cause of it. So not every patient will present you with a fissure. You will just give him GTN and ignore him, because that can be, can be a presentation of a serious disease, underlying disease. Can be cancer, can be, if a skin condition, you will see the skin condition. But the problem is it a cancer? Is it irritable bowel disease? There is a hidden HIV and we don't know about it. So these things need to be investigated and looking further on. And recently I read an article in the BMJ that a lot of people that have been diagnosed as inflammatory bowel disease, they are having actually chlamydia infection rather than inflammatory bowel disease, because it seems to be that the chlamydia can cause inflammation in your gut, in your rectum especially, to the degree that can mimic ulcerative colitis or even Crohn's, usually ulcerative colitis for sure. So cases that present for you with ulcerative colitis, and there is no clear family history that this disease is running in the family. So it's worth doing anal swab and send it for possible sexually transmitted disease, or taking history of their sex, okay, and especially if they are men having sex with men, they can present with symptoms query as inflammatory bowel disease, and they can misdiagnosed as inflammatory bowel disease, and actually they have a chlamydial infection, chronic chlamydial infection, and is not treated. Okay. How to differentiate between acute anal fissure and chronic anal fissure? So acute anal fissure is just a wound, and we'll see a photo now, just a wound in your back passage, and you can diagnose it for the patient clinically. The chronic anal fissure, there will be some fibrosis and skin tags around the anus. Okay, which here clear, so you can see acute redness. Okay, you can see how the wound are fresh, and here how the wound is fibrosed, and then there is skin tags. And the most common site of anal fissure is posterior and in the midline. If it's atypical, then it's worth doing further investigation for it. Okay. Um, Presentation for sure, pain after defecation, okay, and sharp pain during defecation, and the pain usually lasts for a significant amount of time, which is 2 hours around. Treatment wise, well, we have conservative treatment like warm baths, fiber diets, and even laxative with painkillers, okay, paracetamol or ibuprofen, okay. I'm against this tramadol, because you might cause him, constipation, and you make him addicted as well. Okay, sometimes we can use lidocaine, but it's not licensed for that use because of the toxicity. Please be aware that the anal area is one of the sites where the portosystemic shunt is. So you might give him lidocaine cream, and with the overuse, he will have anesthesia toxicity, which is fatal, can cause fatal arrhythmias, convulsions. So just be cautious about that. Lidocaine, usually you might consider using it maybe in pregnant lady also with cautions, because the GTN is, and the other creams, GTN, nifedipine, or other calcium channel blocker are contraindicated during pregnancy. The second light treatment is the GTN cream, diltiazem. And did anyone have experience in prescribing GTN cream in the UK? Anyone prescribe it?
Is it rectogesic?
Proctozec, yeah, exactly.
Yes,
Okay.
I have prescribed.
Yeah, good. And also, I think diltiazem I couldn't find, I think because it was expensive, but I did find nifedipine. So yeah, so if the patient have problem from the GTN cream, okay, like headache or hypotension, then you can consider using nifedipine. And diltiazem, when I prescribe it, the patient couldn't find it, unfortunately. When to refer? Okay, when to refer is important for sure for children. Okay, if the pain for 2 weeks treatment and there is no improvement. If adult with ongoing pain for 8 weeks, even with treatment, or if it's persistent fissure even after 16 weeks, so the fissure is not cured, okay, then you need to refer him. What are the fissure? That's for primary fissures. If they suspect it's a secondary fissure, then you need to refer him, especially if you think that it's malignancy or irritable bowel syndrome disease there, okay, or if it's recurrent. What are the available options? Yeah, botulinum toxins or surgery, sphincterectomy. Then after that will come another question. If this patient having anal sex, when he can have again anal sex after the surgery? Anyone knows? Because it might appear like that. The doctor or the patient will tell you, well, okay, I will do the operation, but when I can have sex after the operation? Or if they have sex before the operation, before complete healing, what is the drawbacks of that? Anyone knows, doctors? Usually 6 weeks. So usually 6 weeks where the complete heal will appear. So it should be there. And then after that, they can have, sex or intercourse. I think we cover most of that. Yeah, this is the other doses of the nifedipine, and what are the uses of the Viagra? What are the uses other than the sexual intercourse, which is pulmonary hypertension? Yeah, I think I finish what I want to say. I will stop the recording, and I'm happy for any question, doctors.